Pneumothorax. In this session, we are going to learn how we can identify pneumothorax in chest X-ray. Pneumothorax is quite common, and it is also very critical that you identify pneumothorax in chest X-ray. So the key findings that you see in the pneumothorax include peripheral hyperlucency, means it is very dark in the periphery, and absence of lung markings, that is the absence of bronchovascular markings. Then you can sometimes identify a line in the periphery, that is the lung margin, also called as the pleural line, partially or completely collapsed lung. Then shift of trachea and mediastinum to the contralateral side in case of moderate or tension pneumothorax. So these are the findings, and in the upcoming x-rays we'll see each of these findings in detail. This is an x-ray of a person following assault with a sharp object. So this is a sharp object. This happened after an alcohol binge drinking. So now here focus on the right lung, and here is this first finding, hyperlucency. So there is a peripheral hyperlucency, right? Compare this lung, how is it, right? And compare here, so it is hyperlucent, or compare this and this. So this peripheral area is hyperlucent, and this line is called the pleural line. This line that is denoting the lung margin is the pleural line. It is the pleural line. So it indicates partially collapsed lung. So this lung is partially collapsed. Then you can see this trachea is shifted to the opposite side, right? It is shifted to the opposite side. You have this thing. And mediastinum, that heart shadows. So normally heart shadow will cross the spine, and some this right heart margin will be somewhere here, but it's now shifted to the opposite side. And if you carefully note here, this is avascular. There is absence of bronchovascular markings. So there is no bronchovascular markings, so this indicates air in the pleural space. So this pneumothorax is secondary to a traumatic injury. So there is air in the pleural space. The air looks dark, and so it is totally dark in the pleural space. The lung has partially collapsed. So since the lung has collapsed, here you don't find any bronchovascular markings. This is the typical pattern in a pneumothorax. You can also note that the trachea is shifted to the opposite side, and the mediastinum, which is represented by the cardiac shadow, is also shifted to the right side. And you can also note that the volume of this hemithorax is slightly enlarged compared to the other side, and the rib space is also relatively enlarged compared to the opposite side. So this indicates a pneumothorax. This is very important. Pneumothorax is very important. As soon as you are walking in an emergency room and someone comes with dyspnea, and you take an x-ray, and you should be able to identify if that is a likely pneumothorax or not. So this is a second x-ray. Now compare this lung with this lung. Here the main thing that I want to show you is that the absence of bronchovascular markings. So you see here, so there is bronchovascular markings. So the entire lung has this bronchovascular markings, and here there is absence of bronchovascular markings. It is hyperlucent, meaning it's very dark. There is absence of bronchovascular markings. The lung is completely collapsed. In the previous x-ray we had lung partially collapsed, and we also said that the peripheral margin of the lung was visible, which we called as the pleural line. Here the lung is completely collapsed. So as soon as you see some x-ray like this, you should be able to make a diagnosis of pneumothorax, because if patient is severely dyspneic, tachypneic and is desaturating, then ideally you might have to put a intercostal drainage. In this X-ray, see the periphery. So here it is hyperlucent. Here you don't see any bronchovascular markings, and this is the partially collapsed lung. I hope you can make this out. This is the partially collapsed lung, this margin. This is also called as the pleural line. So pleural line is visible. So hyperlucency and absence of bronchovascular markings, pleural line indicating partially collapsed lung. And in this X-ray, it is post-treatment. Here you can identify an intercostal drainage tube. If you see this, follow this thing, there is two parallel lines up here, right? And there is some whole sort of thing in the tube, two parallel lines coming. It's coming out into the thorax, right? So this is the ICD. This is post ICD insertion. This X-ray is quite dangerous because here you are having a bilateral pneumothorax. Bilateral pneumothorax are quite dangerous because unless you intervene as soon as possible, the patient can die of asphyxia. So here, focus on this area. It's hyperlucent. Here it's hyperlucent. The periphery is also hyperlucent, right? Here also it's hyperlucent. So hyperlucent. And then you can see this is the margin of the lung. If you note carefully, this is the margin of the lung. This is the margin of the partially collapsed lung. It's up here, right? Here, this is the margin of the partially collapsed lung. So you have air here, your air here. So this is quite rare. It's a quite rare condition because when you have, say it is a bilateral pneumothorax, it's quite rare. So rarely does it occur. But when it occurs, it is a very dangerous condition because both lungs are collapsing, so oxygenation is not happening, so patient will be very tachypneic and he'll be desaturating and he may die anytime. So as soon as you see something like that, bilateral pneumothorax, it's quite rare. Maybe once in a lifetime you might see it, but if you see that, you might have to put a bilateral intercostal drainage. At least you have to put first one side a good drainage so that at least that lung is participating in oxygen exchange, and then you have to put the other side as well. And if you have facilities where two people are there who can put ICD, it's good. Both of them can do it simultaneously. So again, note this hyperlucency, note absence of bronchovascular markings, and note that pleural line, partially collapsed lung. Okay. So another X-ray. So if you look superficially, it looks okay, but now if you see this periphery, so this is a hyperlucent area here. It's a little bit avascular, and then you see you're seeing a margin here, right? So you're seeing a margin. So this indicates a mild pneumothorax. Mild pneumothorax. So in appropriate patients, if patients are stable and if you are doubtful, if things are doubtful and patients are stable, reasonably saturating okay, then you can actually provide oxygen and send for a CT scan if it is in-house in the same hospital and confirm it when you have doubt. Because if patients are stable, then you can do further investigations. Otherwise, you can do a bedside lung ultrasound. Actually, lung ultrasound is much more sensitive and specific in diagnosing pneumothorax. So in a lung ultrasound, you will be seeing absence of the pleural sliding. There will be a shiny, shimmering white sort of light in the ultrasound, which indicates the rubbing of the visceral and parietal pleura. But in case of pneumothorax, that pleural sliding will be absent. So bedside ultrasound is much better than sending the patient to a CT scan if you suspect pneumothorax. Look at this X-ray. So here, this X-ray here, so bronchovascular markings are there. Here it is hyperlucent, absence of bronchovascular markings. So it's not a very good quality X-ray, but this, you can see that this trachea is shifted to the opposite side, right? And even slightly the mediastinum is also shifted. So again, this indicates the right-sided pneumothorax. In this X-ray, right side, you have pleural effusion. So this is a partially collapsed lung. You can see this lung margin. It's a partially collapsed lung. The CPA angle, costophrenic, cardiophrenic angles are obliterated, and then you have fluid here, up here. So fluid is there, the right-sided pleural effusion. And left side, if you see that, it's hyperlucent area, no bronchovascular markings, and this pleural line can be seen here. This partially collapsed lung is seen here. So it is a case of right-sided pleural effusion and left-sided pneumothorax. So this is a bilateral pathology. So trachea is expected to be in midline because here the right side pleural effusion will be pushing the trachea this side, and this sort of pneumothorax will be pushing the trachea from this side. So it has pushing effect from both sides, so likely it should be a position in the center. This is the CT image of a pneumothorax. So you can see this. I just want to familiarize yourselves with CT so that you can identify these findings in X-rays as well. So there's a lung here. This is in the pleural space. So here you can see that the air is in the extrapleural space. So air is here. See, this margin is clear. So here air is in the pleural space. This is a subcutaneous emphysema. It is in the soft tissue plane. So air is leaking here, 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 here. So normally, especially in traumatic pneumothorax, you can encounter subcutaneous emphysema. So here another picture. So this is the pneumothorax. This is the normal lung. This is the pleural line. This is the pneumothorax. Right. So again, CT image of a pneumothorax is a kind of entire lung is collapsed. So this entire thing is hyperlucent and avascular. This is the term that I used, hyperlucent and absence of bronchovascular markings. So you see that it is hyperlucent, it's very dark, and this markings, this bronchovascular markings, and the entire lung parenchyma is absent. So everything is absent. So it's absolutely, if you look something like this, then it is a pneumothorax. So just imagine in the X-ray also we'll have similar thing, except in the X-ray this bronchovascular markings will be absent. Hyperlucency with avascularity, that is absence of bronchovascular markings, will be a good indicator of pneumothorax. Now let's see some of the cases where it looks like pneumothorax, but it may not be a pneumothorax, and this is the first X-ray regarding that. So here you see hyperlucent area, and there is absence of bronchovascular markings inside. You see the bronchovascular marking here, it's absent here, right? So it looks like pneumothorax, but it is it is a large cavity. So sometimes cavities are huge. Post-infectious cavities, some cavities are huge because of some chronic processes. So if you see that the margins, it's all irregular. The margin is quite thick and kind of irregular. So when you encounter this kind of patients, a little bit you have to be careful, because if you do an ICD for this patient, and it will result in you putting the tube into the cavity, and then it can lead to a catastrophe. So if you have a doubt in this kind of situations, it is always best to get a CT scan. And the other thing is, you can see that this if it had been a pneumothorax, that the trachea and mediastinum should have been shifted to the opposite side. But here, if you see the mediastinum, this lung margin is up till the spinal area. So this, whatever the heart shadow, which is supposed to be somewhere here, has shifted towards this side. So there is some sort of a volume reduction that usually happens only in fibrocavity sort of situations, and trachea is not very visible. I assume that it is shifted to the left side, so that also goes against pneumothorax. So this is it's not a, if even if you see that we are not able to see the pleural margins and other findings suggestive of pneumothorax. So whenever I encounter similar situation, it's better to be on a safer side by taking a CT scan. So in this x-ray you see a margin here, and then you have a little bit suspicious sort of thing, but this is a breast shadow. This is a breast shadow, and here also there is a breast shadow. So sometimes there might be a doubt in certain situations where a breast shadow or a skin fold will kind of demarcate something like a pleural line up here, and you might feel that there is a hyperlucency beyond that. So in such situations also you have to be careful. You should not overdiagnose pneumothorax as well, right? So if you have, that's why I'm saying you, if there is a doubt and patient is stable, always ideally you go for a bedside ultrasound if you are skilled enough, or if at all then you have to take a CT scan before confirming a pneumothorax. So here this is a breast shadow. Sometimes you'll have a skin fold that also mimics something similar, and whatever looking beyond will sometimes look hyperlucent because of the breast shadow. This or hypolucency is there, and then it looks hyperlucent, right? So this sort of situations you have to be a bit careful initially. So again, I said previously, this we saw in another x-ray, which is a cavity. Here also it is a cavity. It's a cavity, so don't mistake it for pneumothorax and put ICDs. So see the trachea is pulled to the same side. If it had been pneumothorax, it should have been pushed. See the mediastinum, hard shadow. This is the left side. The cardiac apex should be somewhere here, right? So the hard shadow should come somewhere like this, but it's all the way shifted to this side. So there is volume reduction here. So it's a fibro cavity, and trachea is shifted. It's a large cavity, so never mistake this sort of large cavity for pneumothorax, and never put ICDs in these cases, right? So when it is cavity, you have to be very careful. When in doubt, do a CT scan. So this x-ray suggests emphysema. So hyperinflated. Now in this periphery you are seeing something called the hyperlucent area. So it is a hyperlucent area here, and again if you see that there is no bronchovascular markings up here. So hyperlucency with absence of bronchovascular markings. Now the question is whether it is a pneumothorax or not. So we have to be careful again. Here in these cases sometimes it can be a bulla. So bulla can also be as large as this thing in one particular area with hyperlucency with absence of bronchovascular markings. So one possibility is bulla, and another possibility is pneumothorax. So here we have to be careful. In this x-ray they have put an ICD here. So they have put so likely it was a pneumothorax. So this ICD is visible here, but whenever you encounter something localized, something like round this thing, always keep in mind that bulla can also mimic a pneumothorax. So conclusion, pneumothorax is one of those findings that should not be missed in an x-ray. So you should always correlate with history and look at the peripheries. Usually look at the periphery whether there is a hyperlucency and absence of bronchovascular markings. So in case of supine patients in ICU, there will be something called the deep sulcus sign. The CP angle will be quite deep. That is also an indicator of pneumothorax. But in those cases, you have to do a bedside long ultrasound to confirm the pneumothorax. So cumulative learning. So in the first session I said always to check the CP angle in every x-ray. Then second, compare both the lung volumes. Then never miss a straight line. Straight line can indicate hydropneumothorax. And in this session never miss a pneumothorax. So thank you.